hi, hello, and good afternoon messages in the chat box as it disturbs the flow of the webinar. Please note that this webinar will also be recorded and you will be able to watch it later. A link to the recorded webinar will be soon provided to you. Feel free to share it with your colleagues and among your network. Now we would like to start with the session, and I'm pleased to welcome Dr. Saurabh Pokhariyal, a very special guest. Dr. Pokhariyal is head of Department Nephrology and Renal Transplantation, Manipal Hospital, Delhi. Dr. Pokhariyal is a renowned nephrologist and has been instrumental in setting up Department of Nephrology and Renal Transplant Medicine, including the dialysis unit at leading hospitals in Delhi. So over to you, sir.
Good afternoon, everyone, and thank you, Anubhuti, and thank you, BMJ, for giving me this opportunity to speak on chronic kidney disease and COVID-19. So I'm just going to start by sharing my screen. So when I was given this topic of talking about COVID-19 and chronic kidney disease, there was not much known about how COVID-19 affects the kidneys. And as I'll show to you in the next few slides, the initial data was just about acute kidney injury and the mortality of COVID-19. But before that, let's do a live poll. I think Anubhuti or Reena would be doing it. So I think I'll just carry on with the rest of the presentation. So can you hear me?
Yes, sir, we can hear.
Okay, sorry. So SARS-CoV-2 was first reported in December 2019 as an atypical pneumonia in China, and there's been a lot of literature and news coverage ever since then. The causative agent is a coronavirus, which has been named as the SARS-CoV-2 because SARS was also present, another coronavirus disease back in 2002-2003. The coronavirus has 4 subfamilies, and CoV-2 belongs to the beta lineage of that. And the disease is termed as coronavirus disease 2019, which is shortened as COVID-19. The coronavirus infects humans, cats, bats, pigs, birds, and multiple other animals, including pangolins. So the primary mode of transmission of this is close contact, and it spreads via aerosols, droplets via coughing, sneezing, and procedures. By procedures, I mean high-risk procedures, especially like bronchoscopy, dental procedures, which include drilling, and endoscopies. Surfaces which are contaminated by the virus can stay infected for prolonged periods of time. And so, like in paper or cardboard, it can stay infected for up to 3 to 7 days. The incubation period of this virus is generally considered to be between 2 to 14 days. But the problem is that patients who are infected with this virus can largely be asymptomatic. So in India, the asymptomatic proportion has been reported as varying between 40 to 80% of the patients show no symptoms. But unfortunately, during this asymptomatic phase, the patients are potentially infective, and that's the reason why this disease has spread so effectively and so far and wide. In the lungs, the virus normally attaches to receptors like ACE2, CD147, and DPP4, and then is then internalized into the cell. So the normal primary innate response to viral diseases is production of interferon type 1. But in coronavirus disease, this has been shown to be dampened, and this leads to uncontrolled viral replication. Once this uncontrolled viral replication happens, the cells rupture, cytokines are released, leads to massive influx of the white cells, especially neutrophils and monocytes. As the neutrophils and monocytes kind of act upon the virus and the debris, there's hyperproduction of cytokines, can lead to cytokine storm in a lot of patients. There is also activation of complement, and a prothrombotic stage is also seen. And a thrombotic microangiopathy is now well known to be a part of this disease. The clinical presentation can be variable. Like I said, 40 to 80% of the patients can be asymptomatic. Patients can have minimal symptoms like loss of smell, loss of taste, or symptoms of a typical viral disorder like muscle pains, dry cough. Patients can also then progress to severe pneumonia, acute respiratory distress syndrome, with the involvement of multiple organs, secondary sepsis leading to death. Diarrhea and thrombotic manifestations are now known to be common in COVID-19. And mortality goes up as the patients grow older, or patients who have diabetes, high blood pressure, or cardiovascular disease. Now, what are the mechanisms of kidney injury in COVID-19? So the most common injury seen is acute tubular necrosis, which is essentially the endpoint of a lot of infective disorders and hemodynamic insults. So, a drop in blood pressure can cause acute tubular necrosis. Severe sepsis can cause acute tubular necrosis. The good thing about that is acute tubular necrosis is generally reversible if you can control the underlying or the precipitating cause. There's also complement-mediated thrombotic microangiopathy. If the patients have severe COVID and they have muscle injuries, then rhabdomyolysis and myoglobin can cause kidney injury. There's also very specific glomerular involvement seen in some patients of COVID-19, which we call a collapsing glomerulopathy. Normally, this is seen in a primary glomerular disease called focal segmental glomerulosclerosis. We don't know the importance or the reason why this is happening in COVID, but this has been reported. And so if you look at basic pathogenesis, you have the SARS-CoV-2 virus. It attaches in the alveoli to the ACE2 receptor and then gets internalized. This ACE2 receptor is also widely present in different kinds of epithelial cells in the kidney and renal tubular cells, in the blood vessels on vascular smooth muscle cells, intestinal cells, and cardiomyocytes. In the kidneys, this goes inside, causes damage to the mesangial cells and to the podocytes, which are seen especially in the glomerulus, and can lead to a decrease in GFR, the onset of protein leakage from the kidney, and the onset of blood leakage, hematuria from the kidney. And so this was histopathological analysis of 26 post-mortem findings, in patients with severe COVID-19 in China. And the death was due to respiratory failure, and the kidneys showed aggregation of red blood cells in the peritubular capillaries. There was extensive acute tubular injury. Like I said, this is generally reversible. There was electron microscopy showed that the virus is present in tubules and podocytes, and the nuclear protein was also detected on immunofluorescence. And they concluded that direct parenchymal infection of tubular epithelial cells and podocytes with marked acute tubular injury and erythrocyte aggregation occurs in severe lethal COVID-19. But a patient does not actually need to have severe lethal COVID-19. COVID-19 can cause these findings in various degrees in almost all patients. So what are the poor prognostic markers? We all know, older patients tend to have a poorer outcome. Comorbidities like diabetes, high blood pressure, cardiovascular disease, chronic kidney disease, and autoimmune conditions lead to a poor prognosis. Lymphopenia is a marker of poor prognosis. And biochemical parameters like elevated LDH, D-dimer, interleukin-6, troponin, and ferritin also confer a poorer prognosis in these patients. I've written chronic kidney disease here, but in the initial reports which came out, CKD was actually not included in the poor prognostic markers. Especially the Centers for Disease Control in the US did not initially say that CKD was a difficult disease to control in this, but now the data has come out and we'll just be discussing that. So before we get into that, chronic kidney disease is classified based on two things. One is the glomerular filtration rate, so how well the kidney is filtering the blood. And the second is the leakage of protein from the kidney. So normal proteinuria, mild proteinuria, and severe proteinuria. And GFR more than 90 is considered normal, 60 to 89, and you go all the way down to 15, less than 15 ml per minute, 1.73 meters squared. Body surface area is renal failure or stage 5 chronic kidney disease. So if somebody has poor GFRs, so starting from 30, 44 downwards, and high-grade proteinuria, they are at high risk of cardiovascular disease and mortality in a patient not even with COVID. This is a general classification of CKD, not of CKD and COVID. Patients with normal GFRs and no proteinuria don't have CKD in the absence of markers of kidney damage. The markers of kidney damage are albuminuria, hematuria of kidney origin, electrolyte abnormalities, some pathological or structural abnormalities, and a kidney transplantation. So a kidney transplant patient might have normal GFR, no proteinuria. They are still technically considered as chronic kidney disease. And why is that important? Why are these patients now considered at higher risk for complications of COVID-19? So CKD is a chronic pro-inflammatory state. This has been well known for many, many years. CKD patients have aberrant B and T cell functions. They have, as a baseline, increased levels of pro-inflammatory cytokines. Neutrophils in CKD patients have always been demonstrated to have phagocytic dysfunction. And the T and B cells in these patients have increased rates of apoptosis and generally tend to have lymphopenia. So a chronically inflamed CKD patient is at much higher risk. And in fact, if you look at mortality in CKD patients, the number one cause of mortality is cardiovascular disease. And as their renal function worsens, the second highest cause of mortality in CKD patients is sepsis. So I'll just briefly talk about COVID-19 and chronic kidney disease. But before that, let me give you a flavor of what acute kidney injury, dialysis and transplant patients undergo if they get COVID-19. Just a few slides on that. So the first time in March, this is a report from March, the novel coronavirus and the kidneys, and this was published in Kidney International, which is the premier nephrology journal. Presentation, like I said, fever, cough, myalgia, fatigue, leukopenia, and lymphopenia. Diagnosis we'll ignore. The important thing here was AKI was acute kidney injury was an independent risk factor for patients in hospital mortality. But look at this, the impact of COVID-19 on CKD had not been reported. And this is a report from March coming out of China. So as of March, there was no information on CKD and COVID. The CDC did not consider CKD as a risk factor for severe COVID or mortality from COVID. And you'll see how quickly that changed. This is about a month down the line. This came out after, you can see there are multiple studies done. The incidence of AKI 0.5 to 29%, those actually around 15%. Need for continuous renal replacement therapy can range from 1% to about 17% of patients with COVID and AKI. AKI is obviously more common in the ICU settings because these patients are sicker, 2% non-ICU versus 8.3 in the ICU. And look at the urinary abnormalities. More than half your patients will have proteinuria. Albuminuria is essentially the same here. Hematuria in a quarter of your patients. Half will have roughly both these findings. And by this time in April, they started saying CKD was a comorbid condition responsible, along with cardiovascular disease, diabetes, and hypertension, as responsible for severe COVID and as a risk factor for severe COVID. This is another Kidney International report. Just need to look at two things. Total patients, they looked at 51, half and half dialysis patients and kidney transplant patients. So 26 patients in kidney transplant, 25 dialysis. ARDS happened in 10 out of 25 and 10 out of 26. This is phenomenally high as compared to patients who don't have kidney disease, and mortality rates were about 18%. 7 out of 25 in the dialysis group died, 6 out of 26 in the kidney transplant group died. And so their conclusion was in hospital mortality in dialysis and transplant patients with SARS-CoV-2 infection was higher than previously reported. This is extremely high. General mortality in COVID, has ranged in various countries between 1.5 to 3%. Out here, you're looking at about 16 to 17% in patients who are on dialysis or who had a kidney transplant. And there was this report which came out of India, 19 major hospitals, including AIMS, PGI Chandigarh, SGPGI Lucknow, Medanta, and a host of other hospitals, where they just looked at what happened to the care of patients with kidney diseases in India during the lockdown and the pandemic. Look at this, about a third of the patients started missing their dialysis sessions. 3% required emergency dialysis sessions, most likely because they were missing their dialysis sessions. 4% stopped reporting for dialysis. This is like a descriptive study, but if 4% of your patients stop responding for dialysis and they don't come for the next week or two, you can assume they have died. So this is a very depressing statistic, and 0.36% deaths they reported out of 2,500 patients. Outpatient services were badly hit, drop of about 92% in patients coming to the OPD. 61% reduction in hospital admissions. Teleconsultation was started, but accessed by only a very small number of patients. So their conclusion was lack of preparedness before lockdown resulted in interruption in healthcare services and posed an immediate adverse effect on the outcome of dialysis and kidney disease patients in India. Dr. Agarwal is the HOD of AIMS. So that was AKI, that was transplant, and that was dialysis. But the main topic today is COVID-19 and chronic kidney disease. So like I said, very limited data available. Till March, there was nothing to show that, what CKD did in COVID-19 patients. And it's very difficult to distinguish between acute and chronic kidney disease, especially in the acute setting. So if a hospital patient comes to the hospital with pneumonia, breathlessness, and they have an elevated creatinine, at that time, it's difficult to know whether this has happened suddenly because of sepsis or this is pre-existing kidney disease. So one of the first studies to look at CKD and COVID was from the US, the Centers for Disease Control COVID response team. They looked at 7,000 COVID patients, and they found that patients who had chronic kidney disease were 12 times more likely to require ICU admissions and 9 times more likely to require hospitalization. This was published in June. And this is basically showing the same thing. Patients not requiring hospitalization, baseline of 1, and their incidence is of 1% CKD, 9% requiring hospitalization, 12% ICU admissions made up from patients of CKD. And if you look at this lower graph, CKD actually requires more ICU admissions as compared to the other credited CKD risk, COVID-19 risk factors like cardiovascular disease, diabetes mellitus, chronic lung disease, or chronic liver disease. And this, again, is the interaction, the same thing which we discussed. Chronic kidney disease patients are known to have systemic inflammation even as a baseline. They have deficient immune response to infectious agents. So when they get infected by SARS-CoV, there's viral replication, there's hyperinflammation, leads to tissue injury, and the sequential damage to other organs that leads to death. And apart from that, even if you don't look at the hyperinflammation, chronic kidney disease is associated with risk factors for COVID. So half of our CKD patients nowadays in most urban centers have diabetes as the cause of their renal disease. And most of these diabetic patients, after a few years of chronic kidney disease, will also develop cardiovascular disease. One of the earlier studies from China, again published Kidney International, kidney disease associated with in-hospital death of patients with COVID-19. There's been some criticism of this study because it's a busy slide, but just two things to look at. They looked at 701 patients, 600 had normal baseline creatinines, 101 had elevated creatinines at baseline, so 1/6. But they said CKD was only in 2% of the patients, so that's 14. What about the rest of your 87 patients? And then they said, acute kidney injury was in 36 patients. So 36 and 14 is 50. We still don't have another 51 to account for. So if you ignore all that, because there's a lot of overlap between chronic kidney disease and acute kidney injury here, but look at the mortality. Normal creatinine at baseline, 13% mortality. Elevated creatinine at baseline when the patient gets admitted, 33.7% mortality. That's more than double the rate of mortality. You look at all the patients, 701 patients, 113 deaths, 16% mortality, still half of patients presenting with an elevated creatinine. So renal involvement in a patient predicts a much, much poorer outcome in patients of COVID. And this is again, same thing shown as a graph, normal baseline creatinine, elevated baseline creatinine. This is censored at about 25 days. The mortality rates in people who had elevated creatinines is disproportionately high. But apart from that, they also looked at not just creatinine, but all markers of kidney disease. So if you look at proteinuria versus hematuria, baseline blood urea nitrogen, baseline serum creatinine, peak serum creatinine, presence of acute kidney injury, all significantly associated with a higher mortality. So just proteinuria, if a patient was leaking protein versus patient was not having protein, the green one. This one is 1 plus protein, this is 2 and 3 plus. The higher the proteinuria, the higher the mortality, significantly higher mortality, cumulative incidence of death. Same with hematuria. No hematuria, very low mortality comparatively, but any degree of hematuria, 1 plus or 2 plus or 3 plus, and the mortality disproportionately goes up. Elevated blood urea nitrogen, significant difference in mortality rates. Baseline creatinine, significant difference. Peak serum creatinine, significant. This is a marker of severe kidney injury. Acute kidney injury, again, significant differences in mortalities. Again, they looked at it, look at the odd ratios here. So if you had low-grade proteinuria, your hazard ratio is still 2.4. With 2 plus 3 plus proteinuria, goes up to 6.8. Similarly with hematuria, 3 and 8, which is extremely high. Same elevated creatinines, blood urea nitrogen at baseline, elevated creatinines, peak creatinines, and as your kidney injury worsens, your hazard ratios for mortality keep going up. So all they said was clinicians should increase their awareness of kidney disease in patients with COVID-19. Again, this is very, very significant that all markers of kidney involvement, from proteinuria to hematuria to elevated markers of solute retention like urea nitrogen and creatinine, predict mortality in a very significant manner. Then there was this meta-analysis, but unfortunately not a very good quality, because out of the 84 articles they could select using different keywords for search, only four articles could be selected. So that's really not indicative of what happens, but their pool data showed significant association between CKD and severe COVID-19. So this is severity of disease. The previous study where we looked at was mortality. So mortality is much higher, severity of disease is much worse in patients. The odds ratio was 3.03 if you looked at severity of chronic kidney disease in these patients. This is an article which came out in June, was published 29th June 2020. This is data from March, April, and I think the first half of May. This is from Europe. Impact of renal function on admission in COVID-19 patients, and analysis of the International COVID-19 Registry. And so 758 patients were seen. Mean age was 66 years. 8.5% had a history of CKD, but 30% had impaired function at admission. So that's about 22% of the patients had some form of acute kidney injury. They categorized the patients into three groups: GFR more than 60, which is near normal function; 30 to 60 is moderate decline in function; less than 30 is severe decline in function. Management was all over the place. If you see, a lot of this is no longer being used apart from steroids. Hydroxychloroquine 80%, antibiotics 70%, lopinavir and ritonavir 68.7%. Steroids is now in a much wider use now. At that time, 20% of the patients, ACRBs, interferon, and a monoclonal antibody. And the important thing to look here is if a patient had a GFR more than 60 at baseline, the risk of dying was comparatively lesser as compared to somebody who had a GFR of 30 to 70 or less than 30, significantly higher mortality in these patients. So as your renal function worsens, the risk of dying goes up significantly. A single city experience: patients with chronic kidney disease have a poor prognosis of COVID-19, New York City. Again, 3,391 patients, 210 with chronic kidney disease. This is from the health insurance data. So these were patients diagnosed previously before this, they developed COVID as having had chronic kidney disease. The important number to look here is they identified 210 patients with CKD out of 3,391. Out of these 210 patients, 36 died, which is a 17% mortality. However you look at it, it's nearly 5 times the mortality generally reported in the non-CKD population. And like I said, CKD patients tend to have a higher incidence of diabetes, higher incidence of heart failure, cerebrovascular disease, obesity. And all these, if you look at diabetes, the ones who survived, 55%, but the ones who died, 72% of them had diabetes. Same with atrial fibrillation, 6.9% versus 16.7%. Peripheral arterial disease, 10% versus nearly 20%. So diabetes, chronic kidney disease, and the attendant complications, which we uniformly see in all CKD patients, are all predictors of higher mortality. And CKD gives about a 17% mortality in patients with COVID-19. So what about prevention and treatment of COVID-19 and CKD? There's no vaccine or approved or standardized curative therapy available as of now. All current therapies are considered experimental, and so prevention remains the key. The same thing, which I think is all over media, all over hospitals, all over guidelines: social isolation, distancing, maintenance of hygiene, hand washing, strict use of masks to prevent aerosolization, to prevent droplets. In our patients, in CKD patients, we ask them to avoid unnecessary hospital visits. A lot of our CKD patients are now doing video consults with us. All medications are continued as before. Before I get to some specific treatment, in kidney disease, patients are advised to shield. This is not a term which we use very commonly in India, but that's pretty prevalent in the West. Shielding means these patients are generally asked not to come out of home, generally to avoid almost all forms of contact with other people. And who are these? So patients who've had a kidney transplant, patients who are on dialysis, patients who are over 70 and are on any form of immunosuppression for kidney disease or have been in the past. And if their kidney disease is caused by inflammation. So we see a lot of lupus nephritis. We see patients with rheumatoid arthritis having kidney involvement. These patients have received cyclophosphamide. They've sometimes received rituximab. A lot of them have received long-term steroids. And these patients are generally advised for the last 4 or 5 months, we told them, don't come out of your house at all if possible. Try and avoid contact with anyone. What about the use of RAS blockade? So for, like I said, continue all treatments as before. Angiotensin converting enzyme inhibitors and angiotensin receptor blockers are very widely prescribed in chronic kidney disease because these are the drugs known to retard progression in patients with diabetes and proteinuria. ACE2 expression is increased in diabetes and when you treat somebody with an ACE-ARB. So when you block somebody's angiotensin converting enzyme, or when you block angiotensin receptor 2 with an ARB, the angiotensin cycle passes towards overexpression of ACE2. And we know ACE2 is the receptor for SARS-CoV-2 to attach and then internalize into the membrane or into the cell. So the fear was that this increase in ACE2 may facilitate COVID-19 infection. But in experimental lung injury in animal models, ACE2 has actually been found to be protective. And there are now studies come in, and one of the first ones was a retrospective analysis in the US of 511 patients with COVID-19 with hypertension. And they actually found that severe COVID was less common in patients on ARB therapy. So most nephrology societies, this is nephrology societies, support continuing ACE-ARB and monitoring renal function. The other reason nephrologists want to continue ACE-ARB is because, like I said, a lot of our patients have diabetes, they have cardiovascular disease, and for them, ACE-ARBs can be life-saving. So apart from that, we isolate COVID-19 patients. So if we look at specific treatment, with decreased oxygen saturations and pneumonia, most patients will be hospitalized. Supportive therapy to maintain oxygenation above 92 to 94% saturations, euvolulia, and hemodynamic support. Anticoagulation is now fairly standard. Specific drug therapy in CKD is the same as in the general population. So we use the same drugs in CKD patients with COVID as are used in other patients. So specific therapies are antivirals. The standard of care now is remdesivir in patients who have moderate to severe disease, anti-inflammatory drugs, steroids, dexamethasone, and hydrocortisone, monoclonal antibodies, especially for elevated levels of IL-6. ECMO is used in severe COVID for non-specific cytokine removal and giving the lungs a rest. Vitamin D has been postulated. It's not as a supported therapy or a recommended therapy as of yet, but we know vitamin D has multiple effects on the immune system. And there are certain documented benefits in chronic inflammatory states. Certain future therapies are recombinant soluble ACE2 injections, which would kind of bind the virus in the blood itself and not allow tissue invasion, enhancing the effect of natural killer cells, to kind of take away the virus. So to conclude, CKD patients are at high risk. I've written high risk here, but they're at extremely high risk of developing severe COVID-19. Kidney disease, whether it's acute kidney injury, whether it's chronic kidney disease, whether it's dialysis, whether it's a patient who's received the transplantation, increases mortality in patients with COVID-19. No specific therapy is available, and the treatment is the same as in the non-CKD population. Prevention remains the key. So I think, if there's a single message here, it is you have to prevent this disease from happening in your kidney disease patients. That's why I said shielding is extremely important. Patients who have received a transplant or are immunosuppressed should shield if possible. Thank you so much. So I'd be happy to take questions now.
So, sir, we have some questions for you in the Q&A box.
Yep, I'm just opening those. So most of these questions are not about CKD and COVID. So I'm going to start. You want me to answer all questions? So I think Dr. Anurag Mittal has asked about probiotics, Renal. This is not, what the topic is about, but I'll just tell you, Renal is known to decrease certain uremic toxins, but it doesn't improve kidney function. So it might be as a supportive therapy, but not as a therapy which allows you to kind of do away with dialysis. I think below he's also asked about potassium, K-bind for lowering. There's no oral substitute for that. Certain patients we can use fluid cortisone if their GFR is good enough, or you can use a diuretic, but K-bind remains standard for long-term potassium control. How to manage anemia for CKD stage 5. So creatinine ranging between 6 and 7. So anemia management in CKD is standardized. you look at a person's iron profile. So if they have a transferrin saturation, generally we recommend that their iron saturation should be above 30%. Whereas for the general population, the iron saturation is supposed to be 20% or higher is considered adequate, but in CKD, you need to be 30% or higher. If their iron saturations are fine, then we give them erythropoietin injections based on their body weight. And and then we follow up their hemoglobins every 2 to 4 weeks, and then kind of titrate the dose based on the response. How to manage anemia? Favipiravir produce nephrotoxicity. I'm not really aware of that, but favipiravir right now is not considered a recommended drug, though in India it is being used. I will actually share some more slides with you after the question and answer. But specific about nephrotoxicity, unfortunately, I can't tell you. Most antivirals do have certain amounts of nephrotoxicity. Their use in GFRs below 30 is generally not recommended. Dr. Shazia's question, besides pro-inflammatory state, any other mechanisms by which CKD increases risk of COVID? So pro-inflammatory is one, and second is the immune dysfunction. Patients with CKD have an immune dysfunction also. So they are inflamed, but their immune systems are also not normal. They have dysfunctional neutrophils, they have dysfunctional lymphocytes, and they have a tendency towards lymphopenia. So their immune response by itself is not good. So that's another reason why CKD patients have a higher incidence of death or severe infective disorders. There's a question, what GFR can we use remdesivir? GFR below 30 you generally should avoid. But again, like I said, remdesivir was initially cleared as a compassionate use drug. It has been used in lower GFRs, but we don't have enough data to know what will actually happen. Their cutoff or their recommendation is if the GFR is below 30, you should try and avoid it. Dr. Neeta Kumar says, at one place you say lockdown was harmful, other place you advise not to visit hospitals. I'm not saying that that was the conclusion by the Indian Society of Nephrology, that lockdown was harmful in the sense that the patients couldn't prepare for it. So they couldn't come to hospitals. Dialysis patients still need to come to the hospital for dialysis regardless. Other place I advise not to visit hospitals. So where you can avoid, you should avoid. But a dialysis patient has to get dialyzed. What happened was, if you remember the slide I showed you about the 19 hospitals in India, patients didn't come for dialysis. And dialysis is life-saving. You know, a patient who's CKD5 on dialysis, if they don't come for dialysis 1 or 2 weeks, a lot of them are going to die. And so the option is death versus coming to a hospital and to be potentially exposed to COVID. So I would say come to hospital. So the point was not absolute. It is that patients didn't respond to it because I think maybe, you know, they didn't get time to prepare. Dr. Neeta Kumar also asked, steroids deteriorate CKD and AKD? No, it doesn't. Steroids are used as pretty standard treatment in most glomerular diseases, from minimal change to focal segmental glomerulosclerosis to membranous nephropathy to mesangiocapillary nephropathy to acute interstitial nephritis. So there's no evidence to show that steroids deteriorate chronic kidney disease or acute kidney injury. Why cytokine storm is high in CKD patients? Like I said, they are already pro-inflamed. These patients have already high inflammatory markers. And that's why when they get an infective disorder, this gets magnified. How is treatment decided? This is a question by Didi. I will come to some slides I will share after this, then you can have a look at that. What about role of remdesivir? Again, I've already answered that. This is one question by Jamilu Aliyu, CKD patient with COVID-19. Will she be prescribed steroids, Dexa or hexamethasone or prednisone? So in fact, there's a study yesterday which looked at meta-analysis of 7 studies. Dexamethasone and hydrocortisone are recommended for COVID-19, and they have no adverse renal specific effects in CKD patients, so they should be used. Dr. Subramaniam asks, only solution is prevention. So can the dialysis intervals be modified? They can be modified, but not in a lot of patients, they can't be. A lot of patients have no urine output and they require 3 dialysis, every week. Otherwise they go into pulmonary edema. The association of CKD with increase, is it irrespective of stage of CKD? As the stage of CKD worsens, as the GFR falls, the mortality goes up, which we've shown in multiple graphs. What about role of DEXA for COVID and lung consolidation? I think it's standard therapy now, decreases inflammation. This is a good question by SMJ730GM. Kidney transplant patients on immunosuppression, if they present with moderate to severe COVID, does it require any modification of treatment? Yes, it does. So patients of kidney transplant who get COVID, the first thing that we need to do is get them off mycophenolate or azathioprine, and we keep them on steroids. So most transplant patients are on 3 drugs as immunosuppression: steroids, which is prednisolone, then azathioprine or mycophenolate, and a calcineurin inhibitor, which is tacrolimus or cyclosporin. So the first thing we do is stop their mycophenolate or azathioprine and continue them on tacrolimus and steroids. Now, depending on the severity and the extent of lung injury, we would also stop their tacrolimus, because tacrolimus is a fairly potent immunosuppression, but we will continue their steroids. So this is individualized. Bad lung disease requiring ventilation, a patient in shock, definitely we would stop tacrolimus, but steroids would continue. Remdesivir, I've again answered. Best way to manage cytokine storm is Dr. Amarjeet Gambhir, is a combination of steroids, which is basically a damper for all kinds of inflammatory reactions, and IL-6 blocking monoclonal antibodies. Steroids, Ankit has written, steroids are contraindicated in patients with CKD. No, I don't think that is right. Steroids, we use steroids in a lot of patients with chronic kidney disease, with say rheumatoid arthritis or with lupus or with bronchial asthma, and they are not actually contraindicated in CKD. You just need to keep monitoring these patients for their blood sugars, their blood pressure, and their lipid profile. Megha Natraj has asked about impact of COVID on diabetic nephropathy, diabetic kidney disease stage 1 to 3. This, I'm not aware of Indian registry monitoring this data, but worldwide literature of COVID on CKD. So it's not specific diabetic nephropathy. So all CKD, half would be diabetic nephropathy, has shown that, COVID worsens renal disease, can cause sepsis, can cause mortality, and a higher mortality, and also a higher incidence of severe COVID-19. Prasanna Kumar has asked benefits of use of colchicine 0.5 mg in dialysis patients as prophylaxis. This is being used actually in Africa. And colchicine essentially is a very potent anti-inflammatory, as is evident by its use in acute gouty arthritis. There's no standardized or randomized controlled trials to look at the use or the efficacy, but I do know a few nephrologists who've been using this in their dialysis patients as prophylaxis, and they've reported good results. But unfortunately, like I said, we don't have data which has been studied. So as of now, it is not recommended, but there are people using it. And Megha Natraj, again, opinion of using exercise and dietary interventions, preventive strategies for DKD, CKD, or diabetic using COVID-19. So exercise and dietary interventions are standard recommendations for all patients with diabetes and kidney disease. But using this as a specific way of prophylaxis for COVID-19, I don't know. In patients who've already got COVID-19, exercise is generally out of the question. Dietary interventions to control blood sugars remains important. So there is no reason to, not control their diet. I think that's about all the questions I could take right now. I would like to, if you are okay with it, just share with you the Indian government's guidelines for for treatment of COVID. So can I share my screen? I think BMJ India is sharing their screen. Okay, so let me share my screen now. Just a few slides quickly, and we just scroll down. I kept this after the thank you. I thought people would be interested in this. So the Indian Ministry of Health guidelines, for defining mild, moderate, or severe disease. I would not go into details of this, but I would go down to management. So remember, this first is mild, this is moderate, this is severe disease. Routine paracetamol, vitamin C, zinc is recommended for all. Indian government still recommends the use of hydroxychloroquine, though they have a caveat here that not prescribed routinely, but HCQ in patients, especially with diabetes, hypertension, CVA, CKD, CLD. So our patients generally have CKD and hypertension and diabetes, and they say 400 milligrams BD followed by 400 OD for 4 days. Azithromycin, especially a combination of azithromycin and HCQ, can cause significant problems here. People who have prolonged QTC, so an ECG is mandatory, and that should be, generally followed up in these patients. And secondly, bacterial infections should give ceftriaxone. If it's suspected, treat here also. Coming to specific therapy, mild disease, you don't use anticoagulation. Enoxaparin in moderate to severe disease. Dexa in moderate to severe disease. Methylpred, moderate to severe disease. Yesterday's guidelines from that study I mentioned, 7 studies, and the meta-analysis actually says Dexa and hydrocortisone. But since basically the action remains the same of all the steroids, you could use those as well. In cytokine storm, you can use this for moderate disease. Recommendations for severe disease are not there, but it is being used all across the world, including in India for severe disease as well. Moderate disease, remdesivir, 200 IV OD day 1, 100 IV OD for 4 days. Dysfunction is CKD. The dysfunction CKD here is for GFRs below 30. It's not an absolute contraindication. Like I said, it's a compassionate use drug in severe disease and in people with advanced renal dysfunction or in dialysis patients. It has been used. In moderate disease, convalescent plasma, single dose. In India, it's still not recommended for severe disease, but like I said, this is being used in India for severe disease as well. Lopinavir, ritonavir is no longer recommended by the World Health Organization. It's not being used in Europe and in the US. In India, moderate disease, you can still use it. In India, we're also using ivermectin, but it's not mentioned in the Ministry of Health guidelines. Though, like yesterday, the government of UP, Uttar Pradesh, actually released their guidelines, and ivermectin was being recommended by them for both for prophylaxis as well as for treatment. Interferon has been used in a limited number of cases with moderate disease. So that's where we are right now as far as treatment recommendations by the Indian government is concerned. Any more questions? I think, yeah, that's where we are. I think we've done all questions. Thank you so much. Anubhuti, I would hand over to you now.
Okay, thank you so much, sir, for the wonderful session. Now, requesting all the participants to share your feedback via the email survey, which will be sent to you soon. Hope I'm audible to everyone.
Yes, you are.
Okay. So, we sincerely hope that we have met your academic expectations. I would also like to inform all the participants that BMJ has a 3-month certification course in chronic kidney disease. The course covers the pathophysiology, presentation, diagnosis, its complication, and treatment of CKD. The aim of this course is to help clinicians to provide better management of chronic kidney disease patients. So do visit our website, educationindia.bmj.com, or you can write to marketingindia.bmj.com for further information or you may contact Mr. Aditya Tripathi. So this brings us to the end of today's webinar. And before we conclude, stay safe and God bless you all. Have a wonderful evening ahead.
Thank you so much.